Thank you, Dr. Suhail, for that wonderful talk, although very comprehensive. Can I request Professor Abdul Samad to please join us among the chairpersons? Professor Abdul Samad. And in the interest of time, I would also request the speakers coming up to please stick to time. My next duty is to call on stage Dr. Omer Rana to talk on dealing with calcified coronary lesions with particular focus on rotablation. Thank you.
Great honor to be here, and I am, extremely grateful to Professor Bashir Hanif and Professor Naman Nasir for asking me to give this presentation. My compliments to Professor Suhail Aziz for such an excellent presentation, which has made my job that much harder. Can I have my slides on the screen, please? Okay, thank you. So let's begin. These are my disclosures. So historic data from IVUS studies almost 25 years ago has confirmed that almost 1 in 6 patients will have moderate to severe calcification. And this data has been borne out by studies almost a generation later by using OCT. So calcium is there. The question is, how do we deal with it? Why is calcium so important? Because calcium has been shown repeatedly to be associated with adverse events, whether it's cardiovascular mortality, myocardial infarction, TLR, etc., etc. The mechanistic basis of these clinical findings have been underpinned by bench studies secondary to stent underexpansion and malapposition due to calcium arc as well as calcium depth in the intima. And this data has been borne out in human studies where the degree of calcium dictates stent expansion or underexpansion. Moreover, more recent data has confirmed that stent underexpansion is an independent prognosticator for long-term outcomes. Therefore, we require a lot of treatment options on a day-to-day basis to treat these calcified lesions, and we have a whole array of options ranging from different balloons, Oppian balloons, cutting balloons, angioscope scoring balloons, as well as atherectomy devices, rotational atherectomy, which has been in use for more than 3 decades, orbital atherectomy, excimer laser atherectomy, as well as intravascular lithotripsy. For the purpose of this talk, I'm just going to focus on rotational atherectomy. So the rotablator system was introduced in 1988 by a chap called David Auth. It has the burrs have diamond-tipped crystals, which are several hundreds of them embedded on each burr, and it works on the principle of differential cutting. Elastic tissue, when you run a rotaburr on it, will stretch and will not allow differential cutting. But inelastic tissue, for example, arteries which are calcified, will allow differential cutting, and hence you will be able to ablate the calcium to make space for your balloons and stents. This is a porcine model. On the left side, you'll see a calcified artery just been ballooned to smithereens, and on the right, you'll see a similar artery which is being rotablated, and the difference is obvious. OCT images before rotablation and after rotablation. On the right side, after rotablation, you will be able to, I hope, appreciate that the calcium has been cracked if you look at between 12 and 2 o'clock positions. This is a proposed algorithm for rotational atherectomy use. So once you've decided you want to do intervention, study the angiogram carefully. And if there is a severe calcification, then the answer is that you do require rotational atherectomy. And if you're not sure the calcification is moderate, then some form of intracoronary imaging is required. And if the calcium arc is more than 270 degrees, then you have your answer, and you should use atherectomy. That's the hardware for the rotablator, and that is, I must mention, for the first iteration, which has been used for more than 3 decades. So you got a console, the foot pedal, and tanks regulators, and the nitrogen tank should be at 100 bar to give adequate pressure for the rotablator to work. These are the disposables. So you have the advancer on the left with all the knobs and the wires and fiber optic cables and compressed gas connections. Or below that is the wire clip and the torquer, and on the right side you'll see a typical example of a burr, which comes in various sizes with 0.25 millimeter increments, as well as 2 different wires, a floppy wire and an extra support wire. 99% of my cases I do with floppy wire. The only indication, in my opinion, for an extra support wire is if you want to do an aorto-osteal lesion for support, or the only other indication would be an osteal circumflex, which has a very kind of hyperacute bend. This is the new iteration of the rotablator system called the RotaPro. So they've done away with the foot pedal, and the foot pedal is now on the advancer. I don't know if I have a laser pointer. I think I have one here. Yeah, there we go. So that's that blue button there. That's the foot pedal, which is now the finger pedal, if you like. And that's the console, and here are your connectors. And that is your speed dial. Different burr sizes and guide selection. So from 1.25 you go up to 2.5. I mean, 99% of my cases up to 1.75 burr. 90% of my cases I do with 1.25 burr, and they fit well in a 6 French guide catheter. Post-ablation, the ablated particles are smaller than red blood cells, and unless the technique is very poor, in my experience, slow flow is not really a huge problem when the rotablator has been done properly. And to avoid that, you should select your speed very carefully and use the smallest burr possible. Fundamental elements of rotational atherectomy technique. I'm going to spend some time on this slide. So initially, when the rotablator was introduced, the concept was to debulk the lesion. That was before stents. So they would use the largest burr possible, blow as much calcium to smithereens as possible. But that led to, acute artery occlusion, increased surgical rates, complications, etc., etc. Now the concept is to modify the plaque. And all you want to do is crack the calcium arc. That's all you want to do, because the newer generations of balloons are so good that if you crack the calcium, even if a tiny crack, you can get down with a balloon and then pre-dilate and get your satisfactory result. The rotational speed debate is endless, and this speed is suggested by the European Rota Club. But my personal preference is 180,000 with a 1.25 burr, always, and 160,000 with anything 1.5 millimeter or above. There should be a gradual burr advancement. I mean, I see cases all the time where people, they take a rotaburr and they're just, going into the artery as if they're chiseling a sculpture into shape. And that's not how it works. You have to be very, very patient. I'm basically an impatient man, but when I'm doing rotablation, my cath lab staff, they laugh at me because I'm acting against my nature. And that's how you have to be. You have to be very patient. Short ablation runs, normally I'll do 3 runs in 10 seconds or less. If you do more, you run into problems, you'll have pauses. Avoidance of deceleration, so more than 5,000 RPM. So I'll have 1 lab staff looking at the speed meter for me, because I can't have my 2 eyes on 3 screens. It's not possible. And it should always be followed by a final polishing run. The temporary wire placement is also an endless debate. I never use a temporary wire placement. Never have. The most I've ever done is in very high-risk cases, single artery. I will, put a 5 French sheath femoral. 95% cases are radial, and I will put a temporary wire in the right atrium. That's it. So if I need it, I can just quickly move it into the right ventricle, and I've never had to use it. Because there have been cases of RV perforation after successful rotablation atherectomy, which is a disaster because you still have to open the chest, which you're trying to avoid in the first place. That's a rotablation flushing cocktail. The Rotaglide is not really used anymore. It had albumin and olive oil, caused allergies. I'll show you a case example, which I did last week. This is a 67-year-old gentleman, Hep C positive, previous liver cancer treated, hypertensive, ex-smoker, normal LV function, intractable angina, surgical turn down. So was turned down by two very well-renowned cardiothoracic surgeons in the city where I live. And I hope that I will be able to convince you that the arteries are severely calcified. At least the RCA is, there's this huge ball of calcium sitting there. So I don't know if you can see, but my fine cross microcatheter wouldn't cross. So the image hasn't been captured, so I took the cyan blue wire out, which is my workhorse wire, put a rotor wire down, and then rotablated the RCA with small pecking motion. In the third image, you probably can see at the very end that the rotablated burr nearly got stuck, but was able to pull out. And at the very end, you'll see one final polishing run. That's the final result with one stent implantation. Moved on to do the LAD in the same go. So you'll see a fine cross coming down, the workhorse wire is pulled, rotor wire is introduced, and you'll see a 1.25 millimeter burr in action. And that's the kind of final polishing run, if you like. And after that, in these images, you'll see pre-dilatation, a 275/28 stent, overlapped with a 3038 stent coming into the distal left main, post-dilatation with appropriate sized balloons, and that's the final result. So in conclusion, coronary artery calcification is associated with increased adverse events. The stent underexpansion has been identified as an independent prognosticator. Several devices available to treat coronary artery calcification, balloons, atherectomy devices, and now shockwave. Rotablation is a time-tested and effective technique with a wealth of evidence behind it. Thank you so much.
Thank you, Dr. Omer Rana, for that comprehensive talk. We had a talk on SVG and Lima interventions to be done by Dr. Ahmad Noman, but he has not been able to come due to unforeseen circumstances. So may I directly call on stage Dr. Nadir Khan to talk about the final frontier, the basic tools for CTO interventions, please.